Finals SAQ 95 Phantom Limb Pain. You are called to see a 25-year-old man who suffered a traumatic below knee amputation 24 hours ago. He is using PCA with IV morphine and was comfortable until 2 hours ago when he started to experience severe pain. A. Why might his pain control have become inadequate? This may be caused by failure of morphine delivery. Check syringe is full, pump working well, patient using pump well and cannula is patent. It could be due to acute pain, failure to manage acute pain due to development of infection, wound dehiscence, hematoma formation in the stump. It could be neuropathic pain, development of phantom limb pain. Phantom limb pain occurs as a result of nerve damage, resulting in changes in the nervous system at multiple locations, causing dysfunctional transmission of sensory information and abnormal pain perception. It could be due to other pain sources. Check for coexisting injuries. B. How would you re-establish optimal pain control? First, assessment of pain, degree of psychological distress and physiological effect. IV morphine titrated to effect, with monitoring of oxygen saturations, respiration, heart rate and blood pressure. Increase PCA bolus dose and hourly limit if considered safe to do so. Use a multimodal approach. Ensure regular paracetamol and NSAIDs if appropriate. Consider gabapentinoids. Consider IVI ketamine. Consider sciatic and femoral nerve blocks or even epidural if pain is very severe. C. Which factors would suggest that this patient has phantom limb pain? This includes nature of the pain, shooting, burning, cramping and aching, location of the pain, distal to the stump associated with the missing leg, and degree of pain, apparent disproportion between pain experienced and stimulus applied. D. What further pharmacological options are available for managing phantom limb pain? As per NICE Guidelines 2020, treatment for all neuropathic pain, except trigeminal neuralgia, whereby carbamazepine is used, offer a choice of amitriptyline, duloxetine, gabapentin, or pregabalin as initial treatment for neuropathic pain, except trigeminal neuralgia. If the initial pain treatment is not effective or not tolerated, offer one of the remaining 3 drugs, and consider switching again if the second and third drugs tried are also not effective or not tolerated. Consider tramadol only if acute rescue therapy is needed. Consider capsaicin cream for patients with localized neuropathic pain who wish to avoid or cannot tolerate oral treatments. Do not start the following to treat neuropathic pain in non-specialist settings unless advised by a specialist to do so: cannabis, capsaicin patch, lacosamide, lamotrigine, levetiracetam, morphine, oxcarbazepine, topiramate, long-term tramadol, venlafaxine and valproate. Overall 53.6% pass rate. Additional information on post-amputation pain. This may be categorized as phantom limb pain or residual limb pain. For phantom limb pain, there are painful sensations referred to the absent limb. It is more neuropathic in nature and associated with functional changes in the peripheral and central somatosensory systems. It may also be referred from lesions more proximal to the amputation, such as radiculopathy, neuroma, and musculoskeletal sources. For residual limb pain, this refers to pain localized to the still existing limb, including but not limited to the stump itself. This tends to be more nociceptive. It includes pain due to tissue injuries, heterotopic ossification, direct or referred spinal or peripheral joint pain related to altered biomechanics. It can also result from neuromas or nerve damage above the amputation causing neuropathic pain. Diagnosis: pain associated with the loss of a limb can be considered post-amputation pain. Phantom limb pain and residual limb pain usually presents concurrently, with many amputees reporting features of both. Nociplastic pain may also be present in both post-amputation pain types, or other related pain syndromes spreading beyond the anatomic region of amputation, such as CRPS and post-traumatic fibromyalgia. Non-modifiable risk factors for post-amputation pain includes young age, high degree of trauma, location of amputation, socioeconomic factors and genetics. Potentially modifiable risk factors include psychopathology, surgical approach, anesthetic technique, preoperative and severe post-op pain, and smoking. Mechanisms: phantom limb pain occurs as a result of nerve damage, resulting in changes to the nervous system at multiple locations, causing dysfunctional transmission of sensory information and abnormal pain perception. At the peripheral nerves, upregulation of voltage-gated sodium channels leads to spontaneous firing of damaged nerves peripherally or in the dorsal root ganglia, neuroma development in damaged nerves that are sensitive to chemical and mechanical stimuli. Neural injury due to amputation causes release of pro-inflammatory mediators that lowers the threshold of activation of nociceptors. At the spinal cord, A-beta fibers from Rex laminae 3 and 4 sprout into Rex laminae 1 and 2 due to absence of input from C fibers from amputated limb. Therefore, touch and pressure may be interpreted as pain. NMDA receptors are thought to have a critical role in this phenotypic change. Sympathetic nerves sprout into the DRG, again stimulating pain pathways. Errors in cortical remapping of the homunculus at the somatosensory cortex leads to overamplification of pain experience and touch being interpreted as pain, and pain felt when other structures are touched. This diagram summarizes the distinct and overlapping mechanisms of residual and phantom limb pain, reference from the article by Doshi et al., 2025. This is a multidisciplinary suggested strategy for managing analgesia in limb amputation patients, referenced from Nortin et al., Management of Post-Amputation Pain, ATOTW, 438, 2021. Preoperative, patient education and optimization of mental health, preoperative analgesic optimization, including engagement with acute pain service. Consider placing epidural or regional infusion catheters 24 hours preoperatively. Intraoperative, regional analgesia prior to incision, with or without general anesthesia. Intraoperative ketamine infusion. Paracetamol and NSAIDs unless contraindicated. Other analgesic adjuncts such as IV magnesium and or clonidine as tolerated. Titrate systemic opioids as required. Postoperatively, regular paracetamol and NSAIDs if not contraindicated. Continue epidural or peripheral nerve catheter infusions, if practical and safe. Consider IV ketamine infusion. Systemic opioids only as required. May be delivered as PCA. Minimum daily review by acute pain service team. Continue multidisciplinary approach and comprehensive communication with the patient. Consider referral to pain specialists for persistent pain and or psychiatrists. Consider use of gabapentinoids, calcitonin, and non-pharmacological therapies. Ensure meticulous discharge planning, documentation and handover regarding analgesic plan. This table summarizes the levels of evidence of treatment and prevention of post-amputation pain, reference from Doshi et al.'s article, 2025. For prevention of post-amputation pain, Level 1, none. Level 2, none. Level 3 evidence, targeted muscle re-innervation surgery and patient-controlled opioid analgesia. Level 4 evidence, epidural anesthesia placed more than 24 hours before surgery, including with calcitonin. Catheter-based regional anesthesia. Regenerative peripheral nerve interface surgery and ketamine infusion. Negative evidence for gabapentin and stump wrapping or limb cover with aluminum foil. For treatment of phantom limb pain, Level 1 evidence, none. Level 2 evidence, gabapentin or transcranial direct current stimulation showed short-term benefit. Level 3 evidence, TCAs, NMDA receptor antagonists for short-term benefit, peripheral nerve stimulation, prolonged LA infusion, target muscle re-innervation surgery, and opioids. Level 4 evidence, calcitonin, repetitive transcranial magnetic stimulation, short-term benefit, mirror therapy with virtual reality, showed short-term benefit, regenerative peripheral nerve interface surgery, and neurolysis of painful neuroma. Negative evidence for IV lidocaine, botulinum toxin, and sympathetic box. For treatment of residual limb pain, Level 1 evidence, none. Level 2, none. Level 3, IV lidocaine, prolonged LA infusion, and targeted muscle reinnervation surgery. For level 4 evidence, regenerative peripheral nerve interface surgery and neurolysis of painful neuroma. Negative evidence for botulinum toxin and sympathetic blocks. These are my references. Thank you.